of all, thanks, Dr. Alok, for inviting me. Once again, compliment to you for this wonderful NUCD and with this wonderful idea of keeping the different experts in one session. But at the same time, also I'm congratulating you for reduction of weight also. So you're looking very handsome and smart. Thanks,
Thank you,
Anjali,
thank you.
for introduction. Uh, yes, Dr. Jayant Panda, my close friend. And we have, I think, in this particular session, we have Raji, we have Manoj, we have Jyoti Dev, Anjali, everyone is there. So it will be real great to learn from everyone. I'm just sharing my screen. Jayant, my screen is visible.
Yes,
Visible,
sir.
boss. You
Okay,
have to make it full screen. Yeah,
I have.
it's done.
Thank
Now
you.
you can start.
So first of all, thanks Anjali again, and I'm thanking here Rajiv Kovil because these slides, many of these slides which I have taken from him, because just before some time he was talking on the same topic in before 2 weeks. So I thought if I can have his slide and he had given me, so I'm really thanking Rajiv. And yesterday I asked him also, and he's here, so we will discuss. But his slides I will be talking in a different way. So I don't have any disclosure here, but otherwise I am on advisory board for many of diabetes care pharma. I am also doing clinical research for most of the present and future molecules. At present also I am doing a lot of clinical trials. Now the first very important, that why CGM is the future. In 2013, this paper was published in Critical Care, and it was involving 44,964 patients from 23 intensive care units in 4 continents. And just before some time, the before session was on intensive care, and they were talking about the COVID. But this paper, which was talking about that, quite simply, intermittent monitoring is not up to the task. And we will be asking our nurses to target a discrete range by using insulin, avoid hypoglycemia, and minimize glucose variability. So this is what every critical care consultant or any physician who is admitting his patient, they ask from their nurse, that at least they want their patients to have a good glucose control without hypoglycemia and least glucose variability. They might be doing all these three things with the self-monitoring of blood glucose, but moreover, we can be certain that these intermittent monitoring frequency do not detect every episode of dysglycemia that occurs in our patients. And successful management of all three domains of glycemic control will require the use of continuous or nearly continuous technology to monitor glucose. And I'm sure all of you will agree with this. One of our patient who is doing self-monitoring of blood glucose, as it is recommended, they should check at least 3 to 4 times in a day. A patient on a multiple daily insulin injection, patient is doing early in the morning at the time of wake up, before lunch, before dinner time, and even at bedtime too. And you will know that all 4 reports here are showing almost well controlled: 140, 120, 110, and pre-dinner was around 200. But all reports are absolutely well controlled, and we will consider that this patient is absolutely well controlled. But the same patient, if you put the patient on a continuous glucose monitoring, you will find that actually it is not 100% full-time control. Patient is having pre-lunch hypoglycemia, midnight hypoglycemia, and post-lunch probably he is getting a hyperglycemia also. So I mean, this is what a difference when we are doing a random blood glucose monitoring and when we are doing a continuous glucose monitoring. So simple difference between doing a random blood glucose and doing a continuous glucose monitoring, you can see it's a difference like a videography versus a still photography. The same way, what we do when we do ECG, it just gives the idea at that point of time if there is ischemia, if there is arrhythmia, you can detect. But the difference between an ECG and Holter will be the same difference that is what we get in a random blood glucose monitoring or we get with continuous glucose monitoring. So how do we monitor our glycemic control? One is by self-monitoring of blood glucose. Other is by A1C. Is A1C is enough for managing diabetes? You may have two different type of patient with same A1C. One patient with a less glycemic variability, other patient have multiple hypo and hyperglycemia. So focusing only on A1C may not reveal the complete spectrum of risk for people with diabetes. And you may have the two patients with the same A1C, or the same patients at a multiple times in a year may have a same A1C, but even the difference may be the glycemic pattern, may be the glycemic variability may be different, and even the hypo and hyperglycemia is also different with the same A1C also. So the limitation of current monitoring method is, one is we have A1C, it's a standard of care, we all know, but the impact of hypoglycemia and hyperglycemia are unknown. It does not give you any idea about the glucose variability. While the other is self-monitoring of blood glucose, or randomly glucose monitored, provides glucose information, but at that point of time. Only that point of time you know that what is your glucose level. However, hypoglycemia and hyperglycemia can be completely missed, or often they are missed. Overnight data is almost impractical to get when person is doing self-monitoring of blood glucose. So over the period of almost in a nocturnal time, one may not get the complete reports about how many times person is getting either hypo or hyperglycemia. And log books, when patient comes with the log books, are also very, very difficult to interpret. So these are the limitations of current monitoring methods. So the continuous glucose monitoring is an advanced way of people living with diabetes to check glucose readings in a real time, or monitor glucose reading over a period of time. And we have two varieties of continuous glucose monitoring which are available to us: professional CGM and a real-time CGM. Professional CGM is a glucose monitoring device indicated for detecting trends and tracking pattern in people with diabetes, and real time facilitates the person with diabetes, but they are to be empowered to make much informed decision of managing their diabetes. So if somebody is getting real time all the time, these patients or these persons with diabetes, they should be empowered and they should be educated so they can take the decision and they can manage their sugar also. So we have Freestyle Libre and we have Libre Pro. Both are available. Libre is more like a real-time continuous glucose monitoring, or Libre Pro is more of a professional. We have also Dexcom G4 and G6. Both are available in our country. G4 at present comes with a separate device, while G6, you can see all these reports on your iPhone itself. We have iPro 2, which is Medtronic device, which is again a professional one. And we have Guardian Connect, which is like a real-time continuous glucose monitoring. So these all are available to our country. So if you see the evolution of continuous glucose monitoring, we were having first generation and second generation, but now we have like third generation device which are available to us, which I talk. But in future, we are looking for a fourth generation, which are implantable sensors. They may give you the continuous glucose monitoring reports for next 6 months or 12 months or even 3 months, which is already available in some parts of the world. At present, it is not available in our country. And in future, even like the Google Lens or something which can give you the continuous glucose monitoring continuously, that will be the future of this continuous glucose monitoring. What's the rationale? Why we need this important technology for our patient? The CGM provides a visual feedback to help patients and clinician to understand the glucose variability. CGM is especially beneficial for people who are not meeting their A1C goal. They have frequent low glucose level. They are unaware of their hypoglycemia. They want to reduce A1C target without increasing hypoglycemic events. They have widely variable glucose level, that is widely glycemic variability there. And there are children and adolescents with diabetes who are willing to use this device every day. And one very important for India, they should be affording also, because this is not for everyone. Here the patient has to pay from their pocket. So the affordability is equally very, very important. The challenges which we used to find when we used to do the CGM, this type of data we used to find, and that was very difficult to interpret also. But then there was an ambulatory glucose profile, a app, it's a software which has can be downloaded, and it gives you the complete information about last 7 days, 5 days or 14 days. This AGP is constructed from like a model day plot which collapses glucose data of over several days or weeks, and these data is plotted according to time if they have occurred over 24 hours. So you will get like in 24 hours all these data are there, and then you will get a median, that is what the dark line, and in between the 50% of the time when person is having the sugar level like this, and last a very light gray line is showing you only the 10% of the time person is going either in that level also. So whether really continuous glucose monitoring is helpful for our patient, this is one of the paper of Gold 3 study which had talked about the less hypoglycemia, better social well-being and quality of life with the persons who have continuous glucose monitoring and compared to self-monitoring of blood glucose. This Gold 3 study, the aim was this: to increase understanding of Cgm effect on hypoglycemia in person with type 1 diabetes who are treated with multiple daily insulin injection, to improve the understanding of Cgm effect on hypoglycemia, confidence in daily life in this population. And conclusion of this Gold 3 study was that Cgm reduced the time in hypoglycemia. It improved hypoglycemia related confidence and it improved well-being and quality of life also. The Silver study, it was a continuation of the same study to evaluate the effect of Cgm in adults with type 1 diabetes who are managed with MDI and guidance-based clinical support over 1 year. And these were the patients who had completed Gold trial, were invited to participate in this Silver study, in which 107 patients were continued on Cgm treatment over 1 year. And what they had seen, there was a significant reduction of A1C 0.35. That is significant p-value, and the reduction in time spent in hypoglycemia and hypoglycemia fear, that is more important, and increase in overall well-being, treatment satisfaction and hypoglycemia confidence. And then there was a paper of a Diamond study which was again talking about that 18% of the Cgm group and 4% of usual care group had A1C level below 7. So they could achieve even a target A1C of below 7 with the less risk of hypoglycemia. And average duration of hypoglycemia was 43 minutes per day in patients who were on continuously using glucose monitoring, in compared to the patients who were using self-monitoring of blood glucose 80 minutes in the day in a control group. So there was a significant reduction in A1C with less duration of hypoglycemia in patients on Cgm. So I talked about Gold study, Silver, and then Diamond paper. But this very interesting paper, I think we all know about the DCCT, which was in 1983. At that time, the median A1C of these patients was 9, and target was to achieve for all these patients less than 7, but median they could achieve around 7.2. But what was the risk of hypoglycemia? Severe hypoglycemia rate, which we paid to achieve target A1C of less than 7, which they could not. Median was around 7.2, 62 per 100 patients year. And this was in 1983. After 25 years, in 2008, JDRF Cgm data, Juvenile Diabetic Research Foundation had conducted one study with patients, all patients on a continuous glucose monitoring. The severe hypoglycemia rate was reduced from 62 to 20 per 100 patients here. And here, the baseline median A1C was 7.6, which they could get 7.1. So even the baseline was less, and still they could achieve a very good tighter glycemic control, but very, very significantly less risk of hypoglycemia in compared to DCCT trial. So that's the value of this continuous glucose monitoring or this newer technology in monitoring for diabetic patients, whether they are type 1 or type 2. But this particular was for type 1. The Cgm is an additional asset in the current pandemic. Yes, the Cgm and flash glucose monitoring are useful, and they allow remote monitoring by healthcare providers. And that's the reason this paper, which was published in Diabetes Care in 2020, that glucose is a fifth vital sign in a randomized controlled trial of a continuous glucose monitoring in non-ICU setting. And they had talked that in conclusion, that real-time continuous glucose monitoring can be used successfully in community-based hospital, non-ICU setting to improve glucose management, and continuously streaming glucose reading may truly be the fifth vital sign. And that was paper just recently published during this pandemic. And on the similar ground, we also published one more paper. Dr. Jyoti Dev was the first author about the blood glucose level should be considered as a new vital sign indicative of prognosis during hospitalization. So all patients should be monitored, and preferably those who are in non-ICU, if possible, can we do for a continuous glucose monitoring also. Do we have guidelines which endorse that continuous glucose monitoring should be a way the way we are monitoring our patients. International consensus on use of continuous glucose monitoring in 2017. This was published in Diabetes Care. World experts in the field of continuous glucose monitoring, they were there, and I was also part of this meeting, and we had come with the international consensus on the use of continuous glucose monitoring. Then it was also endorsed by ACE guideline, American Association of Clinical Endocrinology, and they are talking that use of personal CGM device should be considered for those patients who are on intensive insulin therapy, or for those who have history of hypoglycemia unawareness, or those who have recurrent hypoglycemia. So ACE had come out with a consensus statement for use of continuous glucose monitoring. But if you see their guideline, ACE 2020-2020, the 11th principle of comprehensive management of type 2 diabetes. So in a year, I'm not talking of type 1. We had talked many things about type 1 diabetes, where we think that CGM is must. But even for type 2 diabetes also, the use of continuous glucose monitoring, whenever indicated, to assist patients in reaching glycemic goals safely. And that is what CGM is very, very important. Even in their tabular form, where ACE is talking about the managing the glycemic control algorithm, they are talking that lifestyle therapy and an ongoing glucose monitoring is very, very important. At whatever therapy which you are writing to your patient as a first line, second line, third line, at whatever level of A1C when patient is entering, but CGM is preferred. So CGM is being recommended for type 2 diabetic patient in the algorithm, in executive summary, and with the 11 principles of managing type 2 diabetes by American Association of Clinical Endocrinology. And this hints that it has increasing importance of time in range and increasing importance of continuous glucose monitoring. From India also, some of the papers were published. We had done one of the paper with the use of ambulatory glucose profile for improving monitoring and management of type 2 diabetic patients. In JAPI, we published this paper. Again, Dr. Jyoti Dev was part of it. Long back, Dr. Jyoti Dev in 2015 had come out with a guideline for India, consensus guideline for glycemic monitoring in type 1 and type 2 diabetes. That was in 2015. Then one more paper which was again talking about type 2 diabetes patients who are on oral anti-diabetic agents. They are not even on insulin therapy. And in this consensus statement, the using of continuous glucose monitoring at that time, use of ambulatory glucose profile in patients with type 2 diabetes patients. One more paper with Dr. V. Mohan and many of us, Dr. Rajiv and Manoj were also the part of it. And Jyoti Dev, use of retrospective continuous glucose monitoring for optimizing management of type 2 diabetes in India. And recently, Manoj and me had published a consensus statement on continuous glucose monitoring in India during RSSDI 2018. And what we are talking that CGM is mainly applicable for use in following patients: those who have for the on multiple daily insulin injection or on continuous subcutaneous insulin infusion pump, to avoid severe hypoglycemia or repeated hypoglycemia, to reduce the risk of asymptomatic hypoglycemia or nocturnal hypoglycemia, to treat refractory hyperglycemia, particularly when they are fasting, and to take a large blood glucose excursion in GDM or patient with diabetes in pregnancy, understand blood glucose fluctuation which are caused by exercise or meal or stress or by hypoglycemic treatment or with the lifestyle choice, increasing compliance, promote more effective communication between patients and doctors. Diabetic gastroparesis and CGM can also be applied in endocrine and metabolic disorder, including insulinoma. So the three core technology which are actually complementary and essential, and they are complementing each other because we have a large number of patients, they all can't afford to have CGM, but intermittent, they can go for real time or a professional CGM. So the finger stick is very, very important for them to have self-monitoring of blood glucose. The A1C, which gives you an average of that, but every time it does not give every idea about the glycemic variability. And for some of these patients, we must do the continuous glucose monitoring for a better control of glycemia. So this is one of the example which I just want to give here, that how continuous glucose monitoring or a professional CGM can be useful for a type 2 diabetic patient, because most of the physicians in India feel that a use of CGM should be done only in the patients who are on pump therapy or those who are type 1 diabetic patient. This is one of my patients who are was on triple drug, metformin, sulfonylurea and gliptin. Patient A1C was 9. Patient was asked to start the insulin only because on triple drug therapy, sulfonylurea with full dose, Patient was not ready. Patient had come to us, and we had put the patients on ambulatory glucose profile. On fifth day, when patient had come, on sixth day, we asked that, yes, your diet pattern is very wrong. I think better I should start you on a GLP-1. We stopped his uh, gliptin, and we started him on a GLP-1, metformin, and reduced the dose of glimepiride. And every alternate day, we told him we will reduce your glimepiride by half. And in next 5 days, his glimepiride is almost zero. So now this patient was only on GLP-1, SGLT2, and metformin. On 10th day, the last 4 days report was almost absolutely well controlled. And in next 4 days, again, when patient came on 14th day, sugar was well controlled with GLP-1, with SGLT2, and with metformin full dose. So, this is what precisely you can use a drug for that particular person who is having, if we use the continuous glucose monitoring, it is not only for a monitoring or glycemic variability, but to educate the patient, and sometimes even to tell the patient that this will be the best therapy for you, and patient can be convinced once you do the continuous glucose monitoring. So this patient, as per guideline, he should be started with a insulin, but actually this patient is now again on a 3 drugs without glimepiride and gliptin, and now patient is on GLP-1, metformin, SGLT2. So I mean, you can precisely and you can individualize the therapy with the use of continuous glucose monitoring. With this, I summarize my talk that continuous glucose monitoring, it assists in discovering unknown hyper and hypoglycemia. They could be silent or asymptomatic, observation of glycemic variability, assessing percentage of time in or out of range. It also gives you the severity of hypo and hyperglycemia during day and night. It provides actionable information which is derived by continuous glucose monitoring. It highlights impact of behavioral variances, and it analyzes glycemic effect of new intervention effectively and efficiently. Continuous glucose monitoring enhance patient self-management, adherence, and confidence of diabetes. With this, I thank once again, thanks to uh, organizers and everyone, and thanks to Rajiv for giving me slides also. Thank you. Thank you very much.